Hello, and welcome to another edition of the SEANC View podcast. I'm Jonathan Owens, the host, alongside Artis Watkins, Suzanne Beasley, and Sammy Klein, the usual crew. And we have our fifth Beatle in here today, the regular SEANC View guest now. We need to get you a uniform.
A puffin.
A puffin.
Thomas Friedman, the executive administrator of the state health plan. He's going to talk to us a little bit more about what's going on with the plan. First off, I guess we always start with a little talk of the budget. So what is going on? Anything? Probably nothing, right?
Yeah, there's no budget. No budget.
You mean they didn't sneak in like over the weekend?
No, they did not. And like we told you last week, Speaker Hall announced on the floor at the end of session that he did not anticipate any more votes this year. So that leads us to believe that it likely will be short session before we get back to budget.
Okay. Well, that's all that can be said about that.
At the moment, yes, sir.
So with that in mind, no raises on the horizon.
Right.
Members are kind of starting to think, well, my insurance premiums are going up, so I'm going to be in the hole. Less money in my check than I did last year. Thomas, that's why we bring you in. No, we want to talk about, ways that maybe we have a program that can help save some folks some money. And we've touched on it in several different podcasts with you and the Treasurer Brad Briner, about this Lantern program that's coming. And we haven't been able to really dig deep into it, so we thought we'd get Thomas back on the program and talk a little bit more about it. When is it going to be implemented?
Last Monday.
Oh,
Yeah.
okay.
So last Monday, we had our soft launch. We've had over 100 members call already with very light promotion. So I really credit y'all. Thank you for pushing the message out there. It's been in our open enrollment material, but we've launched it for orthopedic and bariatric surgery effective 10/20. So, I think they were expecting maybe 5-10 calls.
Wow.
And we're getting closer to 100 a weekend. Caroline Smart, who's the deputy executive administrator of the plan, always says, people always want us till they get us because they don't realize how big we are and how engaged our folks are. And so I think they're like, wow, folks are really interested and engaged in this program.
Take one big step back, though, and let's remind people what Lantern is and what it does.
Sure. That's great. So Lantern is a program we've partnered with to provide state employees and teachers non-Medicare Prime free options for free elective surgeries across the state of North Carolina with only the highest quality clinicians at those practices. So if you need a hip replacement, think about practices like Emerge Ortho Carolina, those top practices throughout the state. Your surgery, if you go to one of the highest performing doctors in those practices, your knee replacement, your shoulder replacement, hip replacement, you can get those for free. Your surgery is free. The consult beforehand is free. They'll get you in as fast as they can with their highest quality providers. And I think that is a really exciting step. We continue to build out the program to provide more and more options throughout the health systems throughout the state of North Carolina. So we're making great headway there. I think something that's important to highlight, not just the free component of it, and we can kind of provide some more details why we can make it free, but we also want to pay folks if they need to travel, right?
Mm-hmm.
If you're in Murphy, you might not have the same options we do here in Wake County. So if you got to fly to where you need to go in North Carolina, we're going to pay for it. If you need a hotel, you can bring your spouse or a family member or a guardian or whomever. We cover the hotel. If you're going to drive, I drive wherever I can go. We're going to pay for mileage to get that done because we recognize there's not equal access to healthcare everywhere across the state of North Carolina, but all state employees and teachers deserve the highest quality care, and we want to invest in that. So we want to make even the travel to get there. We're going to pay you for, we'll take care of that for you.
We're probably thinking the same thing, Suzanne, but I'm thinking that for rural healthcare, which is such, that remains the problem. People in rural areas having the same access to healthcare, at least for the surgical parts of that, it seems like this is somewhat of an answer. I know everybody doesn't want to travel away from their hometown necessarily to have something done, but if you live in a rural area, you're kind of used to traveling out of your hometown for a lot. And if the health plan's picking up the tab for that and a spouse to go with you so that you have somebody, an advocate.
That's right.
You.
Yeah.
When y'all first told us about it, I was shocked. I think it's a really, really cool thing.
It's pretty amazing that the plan could save money. It just shows the variance in costs across the state, that a plan could save money by paying folks to travel and to get a hotel and still save money over like a local provider or...
Well, and I think it goes to something y'all have been banging the drum on for a long time around price transparency. When you don't have to be transparent, you don't have to compete on price, and you don't have to compete on quality. People become takers of healthcare. I think an example I shared the last time I was here was in one of the northern counties. There's a place where 37 members got diagnostic colonoscopy last year. It was $8,100. If they travel to one of the higher quality centers in Raleigh, that's not that far, it's $1,500. So, the example I used was I could pick all those folks up in a limo, drive them down here, take them to the Umstead afterwards for a few days, pick them up in the limo and drive them back, and we would still save thousands of dollars every encounter.
Wow.
And, that's really the consequence of not having transparent prices. And the consequence of not asking folks to compete on price is, I think a lot of providers go into their rate negotiations every year and be like, 5% more or 4% more, or pick a number percent more. But without really commitments to quality or access. Is the price the right number in the first place?
Yeah.
And we want to kind of shift that paradigm that if you're willing to do something at such a way that our members get it for free and we can save money, we should try to get all our members to go to those providers. And again, only because they're the high quality providers. I know, kind of going back to your rural example, if we said we'd pay for you to go to a doctor who's brand new, who's not very good at things, that's not very respectful to employees. So we kind of have to further that commitment of who's a really high quality provider, who has the fewest accidents, who has the fewest readmissions, who's done the procedure the most times. And, we still pay more than Medicare. We still pay more than Medicaid, a decent amount more. And those folks have done the math. They're good enough business people to realize, like, hey, I'm still making a decent margin on this. And so I'm willing to invest in a population that serves the state, continues to serve the state. Folks stay in state government. Some of us come back. But, folks stick around and, you can build a long-standing relationship with patients and they're willing to make that investment in state employees and teachers. And I think that those are the folks we should want to work with. Those would be the point we should kind of point at and say, like, you should go here.
So I think it's important that we talk about what you mean by free. So if someone, like a state employee, has to have a hip surgery, what would it cost them without this program? They would have their copay, right? And
so there'd be a few things. So they would have, if it was in an outpatient surgical setting, they'd have a copay that is a few $100s. Then they'd pay wherever they are on their deductible. So, and we know the deductibles are going up on all the plans. And then after they hit their deductible, they would get into their coinsurance. So, the range is really going from free to, early in the year, it could be several $1,000s, like a several $1,000 difference.
Okay. So if they do take advantage of this Lantern plan, they would save at least their copay and whatever's left in their deductible.
That's right. So it would be literally zero, when you go sit down.
But their follow-up visits after surgery and like their medication, that wouldn't be free.
Yeah. Correct. That is correct. And the plan is to get to that broader set of bundles and services. We kind of got to build some wins here and some but so it is the surgery that's free. That's right. The PT, we are working really hard on to try to figure out how to get that to a single copay or one or two copays.
Yeah, I just didn't want anybody thinking,
that's
everything about it's going to be free.
That's wonderful clarification. That's absolutely right. But the goal is to build towards
start with the big ticket item, which is the surgery.
Right.
And so over the weekend, I saw something that made me think about the ingenuity y'all are using by doing this program. And it was a hospital in Miami. One of the doctors at that hospital was very proud of this new construction. And it's a nonprofit hospital. The lobby was, it really was pretty. It was a vibe, and looked kind of like a high-end hotel or maybe a large restaurant. Had a piano player in there playing, and he wasn't playing Billy Joel. This guy was playing like Chopin. This was a really nice, well done thing. And
what's wrong with Billy Joel?
The disconnect of the industry, the healthcare industry, with the needs of patients kind of just jumped off the page at you because it said, we'll be so much better able to serve our patients with this. And immediately there was a lot of pushback on that from mainly physicians saying, what in the world? This is not, and some of us said this looks like an exercise in vanity from hospital administrators rather than something to help people. At first, the hospital folks there fought back and said, well, you got to give patients an environment that gives them hope and is nice to be in. But too many people were coming back saying, look, what they want is to be able to go get their health care and then afford the rest of their bills. that's what
Not
they
a piano
want.
player.
Right. They don't care about the piano player. That's nice, but that's not what they want. They ended up taking the post down, and they seemed so shocked, though, at first when they were fighting back in the comments. And I realized, man, this really is a disconnect in this country. And this being a nonprofit hospital, a lot of people were saying, I want you to look into their taxes and everything else. For us, as advocates for members, we don't even care about all that stuff. Somebody else will figure that out. We just want people to know that somebody honestly does care whether they can go get the surgery and pay their light bill this month. And so I am really excited about this Lantern program, and I immediately thought about it. Like, wow, so if you could go get your surgery and you know it's from people who've been vetted out, so they may not have an opulent lobby, but you know that they've been vetted out as effective and well-trained. They've got good, whatever you call the follow-up results after surgery.
Like post-op care? Yeah.
Thank you. Yeah. And that you can be comfortable. I think that's all people care about. It's all they want. People aren't asking for a lot. But especially when they don't get a raise and their prices are going up, they want to see something. And I think y'all are doing something pretty creative without spending extra money to try to keep money in people's pockets.
Well, thank you. And I think the nice thing about this is the more successful we are, the more everyone's costs go down. And the more pressure we can put on the system to not build those fancy lobbies, the more we kind of show them, we're not going to go to your fancy lobby. We are going to go to high quality providers that want to compete on price, that want to compete on access.
Yeah.
That creates more competition. And then we can go to the next phase, which I think is a maternity program that, values the time and efforts of state employees and teachers. And it makes them be more competitive on all of these things. We have the opportunity to, as an individual, make our costs zero and help the rest of our costs go down as well. And that is a unique opportunity. We talk about, y'all have banged the drum for a long time, that we're spending too much money. The best way to spend less money is to show that we're willing to do it. And I think the more successful we are, the more pressure we put on them to be like, I don't care what your lobby looks like. I want to be able to pay my light bill. I want to be able to see my family. I want a good doctor. And that's it. So I would love to work with everyone to make a statement of like, those are the things we care about. And if you want to see any state employees, economic downturn, no matter what happens, state employees show up for work every day. We can be everyone's lifeline and benefit each other across the board. And that's going to change how they think. And I think that's going to take some time, but we can continue to show them like we value quality, we value access, we value transparency and low cost. And this is a chance to hit those who don't want to participate in their wallets rather than them hitting us in our wallets.
Well, we used to hear in the halls of the legislature, we have razor-thin margins. Razor-thin margins. Well, you can have razor-thin margins, obviously, for all kinds of reasons.
Sure.
And I think this will test. Did you have razor-thin margins because you were wasting too much money? Or did you have razor-thin margins truly? Because even with volume, and we expect hospitals to pay physicians and other medical professionals appropriately. But for what we're hearing from physicians and other medical professionals is that's not where the money's going.
No, I mean, you look at any chart and the amount of money that goes to the actual doctor or the nurse is relatively low. It's going to a lot of other different things. And to your point, I don't have a problem with doctors making money if it's going to doctors to providing high quality care and investing in our patients. That sounds great.
Right.
I
want them paid well. I want them comfortable in their life.
Yeah.
I want them
so they stick around.
Happy, healthy, low stress. That's what I want my doctor to be.
And we want them to be in North Carolina, right?
Yeah.
And that's how we're going to do it. And so I think, again, we're going to align our incentives with the provider, the plan, and the member. We want you to be comfortable. We want to be comfortable too, right? And that seems fair and that seems reasonable. And then as long as there are folks that don't want to do that, the folks that do want to do the right thing have a tremendous opportunity to succeed.
Yeah.
So this is not a requirement. There's always that question from members and state employees. They're worried that they're going to be required to get treated. Not maybe that your doctor is already in the Lantern Network, but you are not required to use the Lantern Network. Can you talk about that a little?
So for bariatric surgeries, you will be.
Okay.
Because the cost difference is so significant, we're continuing to grow that network. I mean, 10x in some cases difference. And if we can give it to you for free and save that much money, we're going to do that. But orthopedic surgeries and all the other surgeries we're talking about, no, you're not required to do it. The same benefit you had last year, again, cost sharing went up a little bit. You still have access to those doctors. Right. But I think there's something to be said for if you want to access whomever you want, it is going to be more expensive. If we are giving you the option, if we're doing the work for you, to understand who is a high quality provider, that's really hard to figure out. Like if I had to figure that out on my own for when I'm in a time of crisis and like when I need surgery, like trying to find who the best person is, I don't know if I personally would go through that legwork. So,
and y'all have their specific metrics
that's right.
that you use to vet out these.
And they're different by specialty, right? We're going to look at orthopedic surgeons, what they do at orthopedic surgery, and cardiovascular surgeons and what they do for heart care. Mm-hmm. So we're not taking away access. Candidly, I don't think a system could bear it.
Yeah.
Right.
So I think people talk about, well, you could save $1 bajillion if you go to a narrow network product. I'd be like, yeah, we have hundreds of thousands of people in the Triangle area. No hospital, they've told me, can't take on another couple 100,000 people.
Yeah, that would be wild.
And, we're not going to break the system. We're going to push it. So you can still use whomever you would like.
Right.
It is transparently going to be more expensive than it was last year, and it's more expensive than options you have.
And folks very well may make the decision to use Lantern after they've compared the two. Yeah. They just don't want to feel like they've got to participate
That's right.
in it at this point anyway.
And I think the goal is, you can call Lantern to say, hey, X, Y, and Z is happening, and they'll set you up with a pre-op visit with a surgeon. And if at that point in time, if you don't feel like that person's the person for you, you can still go back the route you were on. We hope you don't. We hope you have a good experience. But just because you meet and do that kind of appointment doesn't mean you have to then go do that with that. We're not doing have-tos. But I would encourage everyone, if they're having that surgery, at least take that step to be like, hey, let's meet this person. Let's meet this team for that pre-op visit. Because they might say, hey, we don't know if you need surgery. You might need PT through Hinge Health that the state health plan is going to pay the entirety of the care for. And then you might not need surgery. Because they are rewarded for saving money on the surgery, but also avoiding surgeries that are unnecessary. I think we all know some surgeries are done more often than they could be.
Scary. Yeah.
So we've empowered their team to say, like, here's some other options for surgeries. But I would encourage you, if you have it, I know you love your doctor, but at least check out what the option could be.
Yeah.
If it doesn't work, you are going to pay more. But again, your choice is your choice, but we would encourage you to at least have that first conversation.
So I have a couple questions, and I think I'll ask this one, building off what you just talked about. So when someone goes to the doctor and they need a procedure, usually they don't even think to ask around or to find someone else.
Yep.
Or even, how do we spread the word about this program? Like, where do you even start to get people to ask questions like that?
So that's a great question. And I think there's 3 or 4 paths. One, we are rolling out our preferred provide network of primary care providers where your copay for primary care is going to be $10 or $15. Through shared savings programs with them, they are going to be incented to partner with those systems that are participating in the program. So if you don't trust me, please trust your primary care physician. In general, I think that's probably pretty sage advice. So we're trying to align incentives and kind of how to share savings across the board. And those are, generally speaking, independent primary care providers. I think once you get in a health system, they're going to tell you to go with
You're ushered to.
Yeah, that's right. Ushered is a good word. 2, if you are referred to, hey, you need to see a specialist for the surgery, please call Lantern and they can help kind of coordinate, do all that work for you, make the appointment on your behalf for this. 3rd, for some of the younger folks, there's an app that you can use the app to figure out who are the providers in the area. You don't want to talk on the phone to someone. That is a plan of choice as well.
They never do.
So we've made that option available for folks as well. You can search for a provider, search for by specialty. You can do that route as well. And 4th, whenever you have questions, please call the state health plan.
Yeah, and I think we can serve a role as well, to spread the word. Obviously, with this podcast, and then, to get
we're going to do a few town halls.
Yes,
and hopefully that'll lead to even more people. They're going to be resistant. I'm that way, and I think most public employees tend to be risk averse. That's why they choose public service, because you kind of have more stability in the job. But it's just a matter of getting everybody used to it. Now, Lantern, my memory of talking to the folks from Lantern is that they have worked with quite a number. Y'all aren't the first people they've worked with. They've done this.
Other states as well.
You give us examples? Can you remember any of the companies?
Yeah, absolutely. So the state of Florida, they're on their 2nd cycle with Lantern. So they selected Lantern several years ago, then did an RFP for bundled surgical services, selected them again. I believe they're also working with the state of Delaware, where I went to school. So that's great. And I believe Alaska as well. And then they have some other large employers. So we are never going to be someone's first client.
Right.
And I chatted with the folks in Florida. They're actually rolling out more services through the Lantern. It's been successful enough that they not only picked them again, but they're rolling out more services like medical infusion, which we are paying an astronomical You want to get angry about prices. I got some data for you.
Don't get me angry.
And then that goes to much more of like a reference pricing fixed cost model for those drug costs that are, commodity to buy. I think it's one thing to charge a lot for a complex surgery. It's another thing if you buy a drug for $1,000 and charge me $5,000, I'm like, I'm not sure that's the same. So other folks are moving a little because they've partnered with them longer, rolling out more services, to your point, because I think, state employees are going to be a little reticent. And I think the job we have to do at the state health plan is change the dynamic around free at the state health plan. Low cost at the state health plan means high quality, better access. Because usually when you hear something's free in healthcare or in anything in your life, you're like, I don't know if that's good. Right?
Yeah.
Like you get what you pay for, right? In addition to like the normal reticence that folks have and kind of risk aversion, that's a conversation you have to really change the language around.
Yeah.
That's going to take some time. And the treasurer comes from a business background. And he's like, I bet you we'll get to X percent in the first year. I'd be like, I divide that by 4. Because it's just going to take time and evolve.
Well, think about it.
Yeah.
It's taken so many years to have a system that's become so convoluted in healthcare that patients, consumers, whoever you want to call us, we've started to just accept the perverse as normal.
That's right.
And only now in recent years where it's reached levels that we can't tolerate it anymore is everybody waking up and saying, wait, it doesn't seem like we have a free market healthcare system.
No, we absolutely don't.
And everybody kind of wants to go back to that. So I feel like, hey, go treasurer's office, bringing capitalism back one hospital at a time. But I think that this is something I would wonder, would you go beyond surgeries at some point if this is successful and look for ways to do this with primary care or with anything else in the industry?
Yes. So we are partnering with a group of physicians across the state to do this for maternity care next.
Oh, wow. Cool.
So trying to get it to one copay from your first OB appointment to delivering a baby.
Oh, wow.
Wow.
That is where, North Carolina has one of the worst infant mortality rates in the country with huge racial and economic disparity differences. It's a problem we got to solve. So I think that's the next organic one. I think primary care is a good example of where we should be going, right? As much care as we can get there. Cancer care that doesn't require surgery, that is really confusing, is really hard to navigate, I think is another kind of natural area and of way to go. Well, the last two I think are a little trickier and more nebulous, but probably the right things to do. I think we do a really good job on behavioral health copays and behavioral health access. A lot of those folks are 1 or 2 care clinician practices, them having to submit a bill every time, charge a copay every time. If you've been with your behavioral health provider for a year and some change, you're probably in a good groove of things. How do we bundle those services? So it's maybe 1 copay, they got to file claims one. Because once you get in a groove with someone, you're probably going to stick around with those people. And then we do not have competitive chiropractic or PT copays at all. Like they're very comfortable saying bad. They're uncompetitive. I pay cash instead of. And we got to do something there. And I think that is an opportunity when we have a diagnosis that has a predictable kind of care pattern to say, it's X, it's X dollars for the copay for the entirety of your treatment of care. And provider, you're responsible for taking care of all those adjustments and all of those things to get the person healthy. Right now, at the transaction level, I don't think that is an effective way to do some of those programs. 1, it puts a lot of administration on that takes time away from delivering healthcare. 3, it's a generally predictable set of amount of time you need someone. And then with the behavioral health one, I think it's the right thing to do, right? If you're focusing on your behavioral health, doing the thing we want you to do, making you pay every time is probably like not the right answer to the question. We've made it very affordable, but those are the kind of the evolutions I see sort of through all those.
So I don't know where this fits in with all of those categories, but we see a lot of things on social media, Facebook. I sent you guys one this morning about scans, like CT scans, MRIs are very expensive, some, and they range in price dramatically. Would that be included somehow?
Scans will definitely, and we are providing, kind of going back to that primary care example, we are trying to incent insurance savings for folks that refer to those lower cost places, not for the referral, but for the savings that they generate for the plan. And again, they can still refer to whomever they want to. But if we want to share in the savings, we got to make it available for members. And I think about, it's also the parking lot experience. If you go to Raleigh Radiology, it's cheaper, it's easier to get in and out of. It's not some big gross deck. I had one more bundle example that we're going to be rolling out next year, Right now, and it is really complicated for primary care providers to do multiple things in a visit, just because kind of how the copay structure works. So if you go in there because your shoulder's bothering you, but you also got a fever, they often have to say like, hey, we can only treat one thing.
Mm-hmm.
And I think a lot of folks don't come back, or the doctor doesn't get compensated for it, or it just creates this whole series of chaos. So in our preferred provider network, we are working out an arrangement with those primary care providers. You can do more. It's not a bundle per se, but it is under that one copay for the member. Please do, and we will compensate you for doing the things you need to do for the patient versus asking someone to.
That's a big deal. I've heard that a lot.
That's a big deal with me because I go to the doctor. I drop like 5 different things on her.
Yeah, and they'll tell you,
Yeah.
no, you're here for this.
Yeah. And so we're trying to work on a structure right now that it works for the primary. And it's going to be those in the preferred provider kind of arrangement.
Okay.
They're the ones that are going to have the prior auths getting taken away, the downcoding taken away. It's just make it a little bit easier for the member. Because, I mean, I wouldn't go back. To be perfectly honest with you, I'd be like, I'm going to ride this out. And like, that's what Dayquil is for. But, a lot of people have more complicated problems than that. So being able to treat the patient while they're there and compensate the provider for the time, that's an antiquated part of insurance of healthcare that doesn't make a tremendous amount of sense to me. So we're going to try to make incremental progress on that.
Awesome.
Well, I have a couple other health plan questions since you're here. But before we wrap up the section about Lantern, tell people exactly where you want them to go to learn more about Lantern and the health plan.
So first, you should be receiving card in the mail shortly. So when something comes up, in your open enrollment material, there is the Lantern website and a way to get to the Lantern app. And if you ever have questions, it is on our website on the State Health Plan. And please call. If you ever have questions, please call. We will get you where you need to go.
Awesome. Could do like a tie-in with Halloween, like don't fear the lantern. Go toward the lantern.
Which, by the way, we're recording this on Wednesday, but it will come out on Halloween. So don't let healthcare be spooky.
Yeah. Speaking of Halloween, that is the end of the open enrollment. So I guess when this comes out, you'll have like maybe 5 hours to do your open enrollment. But how is that going?
I think it's going well. I think fewer folks are making changes than we might have thought because everyone's got a lot of life going on. So I would encourage everyone to take a look at where they are because copays are different.
Now, I've had some tell me they're going to 70/30.
Yeah.
Because of the premiums.
Fewer folks than we would have thought are going to 70/30. I can tell you I'm going to the 70/30 plan.
Yeah.
So
with Lantern out there as
that's
well.
Right.
Yeah.
And a $15 PCP visit and, $15 behavioral health visit. I think that can help for my specific set of circumstances. I think so. I totally understand folks going between plans. I think the folks we're most concerned aren't seeing changes is in the Medicare retirees staying in the 70/30 plan because that is so materially less rich now than the Medicare Advantage plan. I'm a little surprised more folks haven't gone to the Medicare Advantage plan, but again, kind of going back to there's an initial reticence of things. So that would be, I would say, is probably the biggest surprise right now. But we also, it's kind of like a upside down bell curve. We get a lot of folks enroll in the first couple of days and a lot of folks enroll in the last couple of days. And the middle is a little bit.
Yeah.
That's true.
Yeah.
Yeah. People realize, deadline's up.
Yeah. You got the early achievers and the folks that try to get in under the bell.
Yeah.
So recently, with Humana and UNC, there had been this big dispute, and state employees, I'm sure they were calling y'all.
Oh, yeah.
They were retirees. Were calling us who had the Humana Medicare Advantage plan, and we're convinced. And thank you for clearing it up for us so we could try to get the word out to them that Humana, through the health plan, was not affected by that dispute with UNC.
100% correct. If folks get mailers to the contrary, please send them to us.
Yeah.
Because y'all have been great partners.
They were just getting mailers from Humana. It's one of those things. You want everybody to call, so you send it to everybody.
So, but Humana and for the state health plan, UNC remains in network, no changes.
So that brings me to my next question. And I had asked Treasurer Bronner about this a few weeks ago when he was here. And I won't tell you what he said. I want to make sure y'all say the same thing.
Okay.
It's a test.
Okay.
Y'all are a pretty great team, so I'm thinking you're going to pass.
Okay.
Here we go. You ready?
Yeah.
No pressure.
Loretta's not going to like this.
Yeah, Loretta won't let it fly. But so I asked him, since Medicaid is asking providers, look, we need to give you less because we have such a gap to fill. I asked him, did he think that's going to put us in a position of more situations like we faced with Duke, where they wanted more from the health plan, or from the health plan's third-party administrator? I mean, do you think that's what we might be looking at, that hospitals are going to say, if I'm getting less from Medicaid, I'm going to try to fill that hole somewhere, so I'm going to ask a little more from some of my other customers, including the health plan?
I wouldn't be surprised if they try. But remember, we got contracts with a lot of those entities for the next couple of years already flushed out, and we're not going to go back to the negotiating table. Be like, oh yeah, we'd love to give you more money. I think what we're pushing for and where the Duke piece landed was you've got to perform to make more money. You've got to get folks healthier if you want to make more money. So I think the days of us just being very fine with like, you know what, our job isn't to offset that. Our job is to make sure healthcare is sustainable. And something I'm really excited about that is through the Federal Rural Health Transformation Program, a section that the department is going to be working on is how do you, with independent and smaller rural providers, lower the unit cost delivery of healthcare, help them with their EHRs, help them with their rev cycle, help them with AI. So maybe your reimbursement in some areas are going down, but let the treasurer help you as one of the best business people I know, lower the cost to deliver the care. And so we are more focused on how can we help you lower the cost? So if your revenue is not going to go up, how can we help you lower the cost side of things? Because I do not want to be, and I don't think we will be the ones who are being like, we're going to plug the gap. That's just not how this is going to work from my point of view.
Well, and I think in 10 months, y'all have had to deal with an awful lot.
Yeah.
The final thing that I can think of that was so huge being the recent negotiations y'all had with CVS Caremark, the pharmacy benefit manager, the PBM for the plan. And I just went last night to something that IOPL, the Institute of Political Leadership in North Carolina, are such a great organization, and they do these hometown forums, and they've been on healthcare. Last night's was on pharmaceuticals and PBMs. And it was fascinating to me that 10 years ago, that discussion would have been a completely different discussion than it was last night. And the treasurer's office, your office, particularly in the treasurer's office, the health plan, was complemented in the way you have dealt with trying to control your pharmaceutical costs for the plan. So, I mean, I thought that was really nice.
It is really nice. Yeah, I'm glad to hear that's getting out there. And, our job is to fight for teachers and state employees and the costs associated with those things. And we're going to continue to do that. And I think I'm glad we got to a good place with the CVS pieces. And now the big challenge for us with that is now we got to go get great deals on GLP-1 so we can bring those back in some capacity for members in an affordable, sustainable way. So we cleared that hurdle, but now we create, you clear a hurdle to create a challenge. But I feel like, that's where we're going to be marching towards is how do we bring those back? They are necessary, not for everyone who took them. I had a couple too many calls about you're messing up my bikini season. But we have some folks that truly do need them.
That was me. I'm sorry.
Yeah. HIPAA, I couldn't say that. But, we have a lot of folks that need them and it's our job to bring them back. And those drugs provide a lot of value to people's lives and they improve health, which lowers costs.
Right.
So we cleared that hurdle and now we got to clear this next hurdle. And I think we can do it. We're just going to start meeting with manufacturers the next few weeks to what kind of deal can we figure out to bring these back for state employees? And I'm pretty excited about that.
Just an aside on that, are you seeing those costs go down at all? Like it's been out now for a few years, right?
So the cost of GLP-1s have gone down pretty dramatically. But if you look at kind of the data that we're seeing, because we don't cover them right now, so this is anecdote, not our experience. They're, driving costs up in some plans 10 to 20% a year. And it's less so when it's a narrower kind of set of offerings. But, kind of after the last 10 months, to kind of open the floodgates to let's raise our cost 20%. It's probably not where we're going to shoot, but if we can work out an arrangement where they share the value, much like the Lantern providers are sharing in the value that they generate, there's value not just from a health point of view to people having less heart disease, to being in better shape, to, not having to go to the hospital and have heart attacks. Like there's a financial value to that. And we're happy to share that value with manufacturers. But they got to take risk too up front. I think part of this thing with Lantern is these folks are taking risks and a chance too, right? But if we're going to have to
capitalism,
that's right. If we're going to align our incentives. If we're going to take risks and our members are taking risks and costs, y'all are going to take risks too, and that's just what it is.
Well, and we're the only country in the world getting charged those prices.
That's right.
So it's just too much to swallow that. It's gross.
Yeah.
Well, thanks for joining us, Thomas. You have any other questions? You look like you have a question.
I'm good.
Okay.
You covered everything I had on my mind.
I do want to give a quick shout out to Loretta Beniti, who is the communications director is that what her title is?
Sounds right.
Okay. At the treasurer's office, who helps us set these interviews up. I noticed that we've done like 4 or 5 so far, and I haven't given her a shout. You probably remember her from Spectrum News.
Yeah, she was a legend at Spectrum.
Yes, she was one of the first reporters I ever worked with in this job, and I was really nervous, and she helped me along. So shout out to her.
It's a nice lady.
Yes,
and thank you to you and to everyone in your office for coming over.
Fun Loretta story. So she had the black mugs that she gave legislators for doing the interviews with her, and they still have them up. So wherever we're downtown, we sneak pictures of the mugs and send them over to Loretta.
Oh, that's awesome.
Yeah.
That's awesome.
Oh, you never got it. Did you get a mug
I
from?
wasn't a legislator.
Oh,
Only in my mind.
You're important though. I mean, we
Yeah,
could have
okay.
gotten a mug, Loretta.
No mug.
I never got a mug.
I wasn't mug worthy
Yeah.
either.
All right, so we will entrap Thomas with our question of the week. So play my music.
John's wacky weird question of the week.
Okay, it is spooky Halloween season. My daughter and I watched Hocus Pocus last night, but I won't ask the movie question because we had that in an upcoming episode.
Yes.
So the question this week is, what was your favorite Halloween costume growing up?
So my dad wasn't a particularly handy man by any stretch of the imagination, but one year he put on a cardboard box 2 milk jugs that he put scary masks on, cut a hole out. So I got to be a 3-headed monster.
I love it.
One year, and that
That's
was
all.
my favorite one.
Yeah.
Unfortunately, my kids will not even have that level of handiness from their father.
So what are your kids going as?
My son is going as the Grim Reaper for the 2nd year in a row.
His dad runs a health plan.
And my daughter, Maeve, who is a force of nature, is going as Galinda, who she refers to as Belinda. And
So it's Galinda? It's not Glinda?
She changes it.
Oh,
But
I
it
haven't
is
seen
In
it.
case y'all haven't
Galinda.
seen
Yeah.
Wicked,
I haven't seen it. Okay, I'm
Yeah.
sorry.
Yeah.
it's
But
awesome.
that's always been the Glinda the Good Witch, right?
Are y'all going to do
Okay.
trick-or-treating the whole 9 yards?
Oh, yeah. So our neighborhood does a really good job kind of clearing out so everyone can trick or treat. Everyone kind of agrees to not drive, and the kids can just kind of run around. Like when we were younger, you could just kind of run around from the neighborhood.
Yeah.
Yeah, that's awesome.
So my neighborhood, I used to live in like the popular neighborhood in town for Halloween.
Popular neighborhood?
Yeah, so everyone from the whole city from
for
Sanford
Halloween. I thought you
Came-
meant just...
came to our neighborhood because it was like an enclosed loop and you could just let the kids go and it was awesome.
I'm going to ask you offline what neighborhood that is, because I got no idea what you're talking about.
But our new neighborhood, no one trick or treats.
Mm.
So we never get any trick or treaters. So it's so disappointing.
That's very depressing.
Yeah, it's really sad.
Well,
And
what was your Halloween costume, though?
so my brother is like 10 years older than me. So like anything he did was awesome when I was growing up, right? So he bought me Sergeant Slaughter. Remember him from
Oh, yeah.
WWF?
Sure do.
Yeah. So the costume from Walmart that was like a cape. You remember those?
Yeah, yeah.
It was like a little plastic mask. I thought I was something when I was like 5 with the Sergeant Slaughter costume. I think that's like one of the only ones I can really remember. But what about you folks? Sammy, you probably got a bunch of good ones. So what?
I do. When I lived in Tennessee, we used to go to a neighborhood called Sleepy Hollow, and we would walk around there. / my dad would bring the truck, and we'd put a bunch of hay bales, and all of our friends who didn't live in neighborhoods as well would also come, and we'd just jump in and out of the truck with the hay bales.
That's
And I remember my last year living in Tennessee, I dressed because I finally had a dog of my own. That was a small dog.
Oh.
So I was Dorothy,
Oh.
and my dog was Toto.
Oh,
What about you, Suzanne?
Oh, God. I don't know. I was definitely a little girl. You remember the mask where it had the little hole in it? You know, you always stick your tongue through that little hole.
That's what we had, those
Barbie.
hard plastic awful
Yeah.
masks.
It was Barbie. You know, anything Barbie.
Yeah.
So when you were Barbie, I was a Houston
Yeah.
Oiler
Awesome.
with the helmet and everything.
Nice.
Yeah, that kind of says it all, doesn't it?
Yeah.
But that was when the Oilers still existed before they moved to Tennessee to be the Titans. Boop, boop.
How do you feel about Tennessee wearing the Oilers uniforms now?
I just repress it.
Yeah, it's kind of weird, huh? So, two other honorable mention costumes that I've seen. So, at Chapel Hill, you know, Halloween is the big deal, right? The best costume I ever saw was and it's probably not even that great, but it made me laugh a lot, was the guy was just a table. Like he just wore a table.
Oh, the Chapel Hill costumes are the best.
yeah, yeah.
A group of my friends, I was Vanna. This was back when Wheel of Fortune was a big deal. I was Vanna. One of our friends was Pat Sajak, and the third was the wheel. And we made the wheel. It was
Oh,
really
wow. There you
elaborate.
go.
That's awesome.
Oh, yeah. That was a fun.
I actually
The
didn't do
hair
much
was-
during college for
Oh,
Halloween.
the hair was big.
Yeah, it was
when I did
there.
Vanna.
I was more of a stay in my dorm room because my brain just went to everyone does dumb things on Halloween. We didn't have Ubers in my college town. So it wasn't like you had to either rely on a designated driver or you were walking in the freezing cold. So I was like, I'll stay in my dorm room. I'm good right here.
So did you go to Delaware?
I went to Delaware for graduate school. And I went to the University of Arizona for undergraduate.
Oh,
Ubers didn't exist back when I was in college.
yeah. Us either. The only other costume I wanted to mention was one time my son was 9 and he was playing in a baseball tournament in Goldsboro, and they had a game Halloween night. And so after the game, we took the whole team to a neighborhood, and they all were baseball players. So it's like 12 baseball players shows up.
That worked.
Yeah. And so he was a baseball player for like 3 straight years after that because he was too cool for dressing up. So.
And once I moved to North Carolina, my costumes got a lot less extravagant because we just went camping.
Yeah.
We would just go camping Halloween weekend and just
Tradition.
It's a great tradition.
Yeah, so I would still dress up and we'd be riding horses around and I'd just be like Harley Quinn with my double pigtails and just some colored hair. Just for fun.
If you're out there, if you happen to be driving around, be careful of these trick-or-treaters.
Yes.
Watch out for them.
Yeah.
Yeah.
And everybody have a great one.
Great. We'll put some spooky music, the Monster Mash at the end.
That's going to be our theme song this week. It's just spooky music.
Well, thanks for joining us, and we'll see you next week.
Thanks so much.